Welcome to this UCA Urgent Care Association Solutions webinar brought to you by HealthTrack RX. Antibiotic Stewardship, Rapid, Reliable, Responsible Pharyngitis Care, with a focus on diagnostics for the urgent care clinician. Our key message: today's session bridges diagnostic performance and responsible prescribing with a focus on everyday urgent care practice. As mentioned, our goal is to support improving the evaluation and treatment of pharyngitis through evidence-based diagnostics. And we'll see that there's lots of opportunity. So to do that, we'll need to cover some background clinical information, such as the natural history of group A streptococcal pharyngitis, identify non-group A streptococcal causes of acute bacterial pharyngitis, differentiate between viral and bacterial acute pharyngitis, and apply evidence-based strategies. Now, I'm joined by two distinguished industry leaders to talk about this important topic. Let me introduce each of them to you. First, Dr. Shelley Jansen. Hello, Shelley.
Hello, Dr. Goldberg. Hello, everyone out there. Thanks for joining today.
Great to have you with us. Dr. Shelley Jansen, MD, MBA, is the Chief Medical Officer of Novant Health Urgent Care, a 40-site urgent care provider in South Carolina. Hello, Asia.
Hi, Dr. Goldberg. How are you doing today? Good to be here with everyone.
Awesome. Dr. Asia Evans, PhD, is the Director of Medical Affairs for HealthTrack RX. And myself, Steve Goldberg, MD, MBA, I'm the Chief Medical Officer of HealthTrack RX and an urgent care practitioner with University of Louisville Health in Louisville, Kentucky. Here are any relevant financial disclosures for today's webinar. Now, to begin with some foundational knowledge to improve the care of pharyngitis in the urgent care center. Core dilemmas in pharyngitis, evaluation and treatment. 3 topics: colonization versus infection, rapid antigen detection test or RADT performance, and the overlap in clinical presentation. Now, unfortunately, pharyngitis is one of the leading contributors of inappropriate antibiotic use in the outpatient setting. And all of us want to get the diagnosis right and the treatment right. So here are a few initial foundational concepts to consider. Colonization versus infection. Up to 20% of school-age children can be carriers of group A strep without active symptoms. That number declines to about 5% in adults. And considering that can be very, very important as we think about clinical evaluation. Clinicians' concern with rapid antigen detection test performance. What we observe is that there's a high rate of antibiotic prescribing for group A strep RADT negative patients. And we'll talk about that. And finally, and maybe most difficult, the overlap in clinical presentation between group A strep and non-group A strep bacterial infection and viral pharyngitis. Viral pathogens and other bacterial organisms can present with sore throat and tonsillar exudate and can lead to a pharyngitis diagnosis. And so let's think about, in the upcoming slides, what we can do clinically and also with diagnostics to help us get the diagnosis and treatment correct. Again, a first focus on group A strep colonization, and we're saying it for purposes of emphasis. Children 5 to 15 can be colonized with group A strep 10 to 20%, and in some communities up to 25%. This number declines to less than 5%. The seasonal peak of group A strep pharyngitis infection is late fall through early spring, but it's highest in the winter between December and March. So a key message: a positive RADT or culture in an otherwise well patient may simply reflect colonization rather than active infection. And finally, the risk for inappropriate treatment, children who are colonized and are patients who have low pretest probability, who test positive and receive antibiotics. So let's talk about pre-test positivity. Please see these illustrations. We'll talk about each of them. First, to the left, the center score, since modified with a McIsaac criteria, which adds an age element to the original Centaur score. Above to the right, classic predictors of symptomatic group A strep pharyngitis. And to the bottom, score interpretation, what is generally called the modified Centaur score, and how to interpret the findings and what direction it recommends with regard to testing. The primary evidence-supported value of the modified Centaur score is select those that should not be tested with rapid antigen detection or culture or molecular testing, because they have low pretest probability of having an active symptomatic group A strep infection. And the use of these clinical tools versus empiric decision-making, despite some limitations, was recently reaffirmed in an ISDA, Infection Disease Society of America, clinical practice guideline on October 15th of this year. Applying these tools leads to a significant reduction in unnecessary testing by 25 to 40%, and a reduction in unnecessary antibiotic prescribing by 20 to 40% without any evidence of subsequent complications. Very impressive findings. And with use of a decision aid, when one ultimately selects to test someone, the number needed to treat is just 4 to 5 to be able to prevent one inappropriate antibiotic course. So it's a very efficient way to improve the workup. And finally, IDSA and CDC explicitly recommend against empiric antibiotic treatment, and that was reaffirmed in the IDSA 10-15-25 guideline. A bit more on colonization and some practical do's and don'ts. A mention again about group A strep, and a mention of group C, G strep, and finally group B strep. We've mentioned again, group A strep carriage can be common and significant. And consider also that recurrent group A strep positive in patients who are having minimal symptoms likely reflects carriage and not recurrent infection. So this should cause the clinician to pause before thinking about repeated antibiotic use. Group C, Group G strep, these can be associated with foodborne outbreaks in adolescents and young adults. And in general, they resolve on their own and treatment is not indicated. There's not evidence treating shortens the illness, and there's minimal nominal risk for acute rheumatic fever. And finally, group B strep colonization of the oropharynx can also be found in the young and also healthy adults, but it rarely causes pharyngitis. And detection on a multiplex PCR test does not equal infection and should not trigger antibiotics. So again, key message, first focus on clinical evaluation and put test findings in the context of the clinical evaluation. Now that we've talked about these foundational points, let's put what we know into practice. Dr. Jansen.
Thanks, Dr. Goldberg. Because the patient's history and physical exam determine if the patient will be tested and how the test results will be interpreted, it's essential for the patient to be evaluated for features of viral versus bacterial infection as a first step. As Dr. Goldberg mentioned, decision support tools such as the modified Centaur score use these criteria to guide clinicians in the diagnosis and treatment of acute pharyngitis. Standing orders for strep testing are common practice in many outpatient and urgent care settings. Often used to streamline the testing process for the sake of efficiency, support staff are not only relied upon to properly collect the throat swab sample and perform the test, but also to apply the clinical criteria used in the standing order protocol. When used inappropriately, standing orders can lead to testing patients with a low probability of having clinical group A strep pharyngitis and inappropriately treating those who are carriers of group A strep. On the topic of sampling, inadequately swabbing the tonsils and posterior pharynx for rapid antigen detection testing or for culture may lead to false negative results and the consequences of missing acute group A strep infection. As the slide demonstrates, samples should be collected by swabbing the posterior pharyngeal wall, the tonsillar pillars, and tonsils. The swab should not be used to swab the soft palate and should not touch the tongue. Next, we'll talk about determining pretest probability. Using clinical prediction rules to estimate the pretest probability that a patient's pharyngitis is indeed caused by group A strep guides the decision whether to withhold testing and treat the patient for viral pharyngitis or to test for group A strep using rapid antigen detection testing. Those with an intermediate to high pretest probability of having group A strep pharyngitis based on the clinical scoring system should be tested for group A strep using a rapid antigen detection test. Even at-risk individuals should be strongly considered for testing. At-risk individuals include patients presenting with sore throat who've had household exposure to group A strep, patients with a history of rheumatic fever, and those with signs or symptoms suggestive of a complicated local or systemic group A strep infection. Patients whose scoring fall into the intermediate risk range typically have a 15 to 35% risk of having group A strep. This risk is too high to dismiss the infection because it could lead to the sequelae of group A strep, and too low to initiate antibiotics based solely on clinical judgment. Patients whose scoring fall into the high risk range typically have a 50-50 chance of having group A strep pharyngitis. Older guidelines from organizations such as the American Academy of Family Physicians recommended starting antibiotics for patients with a score of 4 to 5 or a high pretest probability. However, the recent IDSA guidelines recommend against empiric treatment, instead suggest treating only if test results are positive. Here's a clinical pearl. A positive rapid antigen detection test in an adult with no classic features of group A strep is more likely due to colonization than acute infection. This statement is supported by two key pieces of data: the low prevalence of acute group A strep infection in adults without classic symptoms, and the well-documented prevalence of asymptomatic group A strep colonization that occurs even in adults. Treating group A strep carriers with antibiotics does not reduce transmission rates, as carriers rarely transmit group A strep, nor do carriers develop complications associated with acute group A strep infections. Avoiding the use of unnecessary antibiotics minimizes a patient's risk of antibiotic adverse effects. Educating patients on the difference between the two main causes of pharyngitis, viral and bacterial, the clinical scoring tools we use to estimate their chance of having a group A strep infection, and the direct harm and societal risk of any inappropriate antibiotic use will help build patient trust. Focus that can then be directed toward achieving symptomatic relief. Next, Dr. Evans will discuss the different testing modalities used to diagnose acute pharyngitis.
Thank you, Dr. Jansen. Now that Drs. Goldberg and Jansen have had a chance to go through the clinical features of what may influence when and when not to test, I want to talk about the different diagnostic methodologies that you have to choose from when determining which tests to perform for your patients. There are three common methodologies that are most often utilized in the urgent care and pediatric settings. Those include rapid antigen detection tests, or RADT tests, culture-based testing like a throat culture, or nucleic acid amplification tests, often referred to as molecular testing, of which PCR is a subset of. Each of these have their various benefits and drawbacks, and so when considering these in your decision of which to utilize, there's several things to consider. So first, rapid antigen testing. The biggest benefit of rapid antigen testing is that it's a fast test that you can get a result from within 15 minutes before that patient ever leaves your clinic. It has moderately high sensitivity, not as high as culture and PCR-based test methodologies. Their sensitivity is higher than what we observe for influenza and COVID-based rapid antigen testing. It does have high specificity, 95%, which is very comparable to the other specificity of both culture and PCR tests. However, because it does have a moderate sensitivity range, it is recommended to confirm pediatric patients with a negative rapid antigen test via throat culture. One of the things also to consider when choosing your rapid antigen-based test is what pathogens are included in your differential, and group-based strep and rapid antigen testing is only available for group-based strep and select other viral pathogens. When we think about throat culture, this has traditionally been thought of as the gold standard in pediatrics. It has relatively high sensitivity of 90% or higher in some instances, high specificity of 95%, and results are typically returned in 48 hours. It has the additional benefit of that it can detect multiple beta hemolytic streptococcus species like group A strep, group C and G strep if that's of clinical concern for you, or other beta hemolytic strep species. Because of the slower turnaround time compared to what's observed for rapid antigen testing, culture is no longer often utilized as a first-line diagnostic and is really reserved for confirmatory testing. Nucleic acid amplification tests, or I'll refer to as NAAT, have high sensitivity. While it is variable based on manufacturer of the diagnostic test, it tends to be either comparable to culture at 90% or higher, in some cases 95%. It does have high specificity like the other test methodologies, 95%, and depending on what diagnostic platform you're using, you can have results in as quickly as 15 minutes or 48 hours, depending on which clinical reference laboratory you are utilizing. PCR testing or NAT testing does have the added benefit that it can test both viral and bacterial targets in the same collection. So if you are trying to differentiate clinically between viral pharyngitis and bacterial pharyngitis, there are both point of care test and clinical laboratory test based options that can cover both of those pathogens. And because it does have high sensitivity and specificity, it doesn't require confirmatory testing. It can be a standalone diagnostic, not requiring any culture confirmation. On the next slide, we will talk about the various etiologic causes of pharyngitis. And while there are two main groups most people think of, bacterial pharyngitis and viral pharyngitis, I like to think of it as there are really three main etiology buckets. You have your standard group A strep bacterial pharyngitis, you have your non-group A strep bacterial pharyngitis, and you have your viral pharyngitis causes. So when we're looking at the bacterial causes, let's focus on group A strep first. Group A strep, along with the viral organisms, which we'll talk about subsequently, should really be considered as first in the differential when you have a patient that's coming in with sore throat, fever, and absence of those respiratory symptoms that really lead you to think it's more of a respiratory virus rather than pharyngitis. Together, group A strep and the viral organisms actually account for 80% of all pharyngitis cases, and thus they should always be the things that you're considered first. The other bacterial causes of pharyngitis, like group C and G strep, Fusobacterium, Mycoplasma pneumoniae, and Chlamydia pneumoniae, when you have a moderately high center score, but a rapid antigen test for group A strep is negative. This is really because these organisms often present very similarly to what you see for group A strep, still leading to a moderate or high center score, but they can also be associated with recurrent and prolonged infection. So when your first line defense of testing for group A strep or viral organisms is negative, that's when these organisms should really be considered. I want to talk briefly about Corynebacterium species. These ones are not often tested for in the US due to their extremely low prevalence. They are typically of higher concern in developing countries. The classic symptoms of when Corynebacterium species should be considered is really hallmarked by the extreme neck swelling that comes from a Corynebacterium infection. And the risk of these organisms in most outpatient clinics is relatively minimal because of the low circulation rates. However, if you do observe symptoms that are indicative of a Corynebacterium infection, like that extreme neck swelling, you're more likely to see these patients are more likely to be managed in a hospital-based or an infectious disease-based environment, not necessarily urgent care. The STI causes of pharyngitis, Chlamydia trachomatis and Neisseria gonorrhea, often present very similarly to a group A strep pharyngitis or a standard bacterial pharyngitis. And presentation of these should be considered in the differential when you have a patient presenting with high risk behavior or concern of exposure. While there isn't a clear presentation difference between what you would expect of other bacterial organisms, testing for these is really reserved for those patients where you do have that concern of high risk behavior. And circling back to the viral pathogens that cause pharyngitis, there are several different viral organisms that have been associated with a moderate centaur score, or even some instances a high centaur score, when you should consider them as part of the differential versus when you should consider them as a standalone viral respiratory test really comes back to that clinical criteria that both Drs. Goldberg and Jansen discussed. If you have a patient who has a low modified centaur criteria, a lot of times testing isn't necessarily needed for these pathogens in cases because a lot of times it's self-explanatory. However, when should you test them? It really comes down to when you do have that moderate modified centaur score of 2, 3, or higher, and you are trying to differentiate between a bacterial cause of pharyngitis versus a viral cause of pharyngitis, as testing for these viral organisms can really help to contribute to appropriate antibiotic prescribing. So piggybacking off of that onto the next slide, what are the reasons that we actually prescribe for pharyngitis? When we think of other bacterial organisms that cause acute upper respiratory tract infections, guidelines typically specify not to treat these, as symptoms often resolve on their own without antibiotics. A classic example of this is Streptococcus pyogenes in an acute upper respiratory tract infection. A lot of times that doesn't require treatment and it can present very similar to a common cold. So why, when we think about pharyngitis, is group A strep and some of these other bacterial causes different? The primary driver for treating group A strep pharyngitis actually comes down to the risk of complications that are associated with them. Group A strep incidence rate is between, as we discussed previously, is between 10 to 20%. And while there is moderate and low risk of both moderate and severe complications, the risk of complications really are the drivers of what actually lead to treating of these. So with group A strep, you can have recurrence and abscess. Those are going to be your mild and moderate complications, but you can have more severe complications like rheumatic fever, glomerulonephritis, and scarlet fever. The other bacterial causes of pharyngitis have similar complication rates. However, due in general to their lower incidence rate, they're often not tested for as a first line in bacterial pharyngitis cases. Group C and G strep, while it does have a similar incidence rate to group A strep, Dr. Goldberg indicated previously in this presentation that the risk of complication is relatively low. Complications with group C and G strep are really reserved to recurrence and abscess and not the same more severe complications that you're likely to see with group A strep. Fusobacterium is an under-recognized cause of pharyngitis, and it does have moderate incidence rate. Regarding complications, it can also contribute to recurrence and abscess. It is also recognized as the primary cause of Lemire syndrome when it spreads to the internal jugular vein. Fusobacterium should really be considered in the differential, like I mentioned on the previous slide, in cases of more recurrent or prolonged pharyngitis because of that lower incidence rate, as it can be a colonizer of the oral cavity and be implicated in dental abscesses and dental infections as well. Mycoplasma pneumoniae and chlamydia pneumoniae, while they have a relatively low incidence of pharyngitis, they're typically thought of to be associated with lower respiratory tract infections. However, in the absence of lower respiratory tract symptoms, detection of these organisms has also been associated with cases of pharyngitis. The incidence of this in pharyngitis is relatively low, about 5%, and as such, the complications associated with these organisms is actually more often associated with a lower respiratory tract infection and are documented to be rare. Corynebacterium species, while it has the lowest incidence rate, it does have the highest complication rate. It can lead to myocarditis, polyneuropathies, airway obstructions, and in many cases, death as well. Like I mentioned, though, on the prior slide where we talked about when this should be considered as part of the differential, it really should be considered when you have that extreme neck swelling as well. And if you do see that, because of the severity and the risk associated for the patient, they should really be considered to be referred to the hospital or infectious disease physicians for management. On the next slide, I think the next logical question when I think about, what are the drivers behind antibiotic prescribing for pharyngitis is, does antibiotic prescribing actually contribute to preventing those complications that we just discussed? Now, when we think of group A strep, obviously that's what we're most concerned about in cases of bacterial pharyngitis. So treating with antibiotics, yes, you can acute rheumatic fever, but you can't always prevent the glomerulonephritis or in cases of infective endocarditis as well. But antibiotic prescribing has been associated with preventing peritonsillar abscesses. And so when we kind of sum all of that up, we really think about, what are those drivers that are leading to prescribing and what is the benefit to the patient? Obviously, there's the preventing acute rheumatic fever. You do have the ability to shorten symptom duration by about 1 day. You do also reduce the risk of transmission, which is a huge driver of antibiotic prescribing. And you do also risk some of those more mild or moderate complications associated with it as well. Next, we're going to turn to apply much of the clinical knowledge that Dr. Goldberg and Dr. Jansen walked through, as well as choosing the appropriate diagnostic test in a couple of case presentations that Dr. Goldberg will walk us through.
Thank you, Dr. Evans. Wow, we've covered a lot of ground, covered a lot of opportunity, a lot of foundational knowledge. So let's put what we've learned into practice with a case. First, I'll remind us all from an earlier slide about the risk assessment, the clinical scoring system in children and adults. We're using what's called the modified Centaur score. It has attributes that get points: tonsillar exudate, fever, cervical adenopathy, absence of a cough, and then the age. It's more common in younger people. And then we talked about classic predictors of group A strep pharyngitis. And finally, we talked about score interpretation. 0 to 1, low risk; 2 to 3, intermediate risk; greater than 4, high risk. That's pre-diagnostic testing probability for group A strep. So let's take the knowledge that we've learned and apply to some cases. And this is a doozy and quite common. A 7-year-old presenting to the urgent care clinic with cough, rhinorrhea, and sore throat. Let's ask yourself, is that a classic group A strep presentation? Continuing, on exam, given what we know, we're not seeing note of fever. We're not seeing note of exudate on the tonsils. We're not seeing cervical adenopathy. So the modified Centaur score will be low. But prior to you seeing the patient, a staff member, per protocol, has ordered a rapid antigen detection test. Dr. Jansen, how might we manage through this conundrum?
Let's go back and assume the pretest probability was determined using the modified Centaur scoring system before that rapid antigen detection strep test was done. According to the modified Centaur score, this patient had low pretest probability of group A strep pharyngitis, and the rapid antigen testing was not indicated. This patient should have been diagnosed with viral pharyngitis with treatment directed at symptomatic relief. This includes pain relievers such as acetaminophen and ibuprofen, but not prednisone. Of note, aspirin should be avoided in children due to the rare but potentially fatal condition known as Reye's syndrome. This case illustrates the pitfalls of standing orders. Parents often equate a positive test result with a current, active, and threatening infection that must be treated. They may not grasp the concept of a carrier state where bacteria are present in the throat but not causing the current illness. So it does create quite a conundrum for the clinician. This slide outlines a stewardship-aligned diagnostic and treatment algorithm. In patients with intermediate to high pretest probability of having group A strep pharyngitis, testing is most beneficial. Clinicians can reliably treat patients with positive test results in these risk groups. For negative rapid antigen detection tests in these patients, however, follow-up may be indicated, as Dr. Evans mentioned earlier. The American Academy of Pediatrics guidelines strongly recommend obtaining a throat culture to back up a negative RADT in children and adolescents, typically aged 3 to 18 years. The Infectious Disease Society guidelines were updated a few weeks ago, as Dr. Goldberg mentioned, and included the recommendation to confirm negative rapid antigen detection tests with throat culture or molecular testing in children and adolescents. In adults with intermediate to high pretest probability of having group A strep pharyngitis, confirmation of a negative rapid antigen detection test is also recommended to improve diagnostic sensitivity, though the risk of complications is lower in this demographic. Penicillin and amoxicillin remain the preferred first-line antibiotics for group A strep pharyngitis, with a standard 10-day course of treatment. For patients with non-anaphylactic penicillin allergy, first-generation cephalosporins are recommended, with macrolides and clindamycin as alternatives. Clinicians should be aware of local macrolide resistant rates when considering prescribing azithromycin for Group A strep. This treatment versus no treatment algorithm summarizes the recommended pathways for testing and managing patients based on their symptoms and rapid antigen detection test results. When the rapid antigen detection test results and symptoms align, no further testing is needed. It's when symptoms are present, but the rapid antigen test is negative, that throat culture or nucleic acid amplification testing can guide clinical management, especially in children due to the higher incidence of acute rheumatic fever. As you can see from the algorithm, no treatment is indicated when classic pharyngitis symptoms are absent. And in fact, no testing is indicated when classic pharyngitis symptoms are absent. Further testing is also indicated for those that present with recurrent pharyngitis. In these patients, a multiplex nucleic acid amplification test that includes common bacterial and viral causes of pharyngitis is recommended, even when the rapid antigen detection test is positive. This step is necessary to increase the diagnostic certainty and rule out other potential causes. Keep in mind that non-infectious etiologies may also be the cause of pharyngitis. These include gastroesophageal reflux disease, allergic rhinitis with postnasal drainage, and the inhalation of toxic fumes. Remember that standing orders can create clinical confusion and make it difficult for clinicians to avoid unnecessary antibiotic prescribing. Up next, Dr. Evans will discuss how diagnostic stewardship can support antibiotic stewardship.
Thank you, Dr. Jansen. In this case example, it really highlights a few key points that I think are important to acknowledge. One, most specifically, though, is that testing for viral organisms can really support proper antibiotic avoidance in scenarios where you do have Group A strep colonization that's positive via rapid antigen test, but you still have that low center score. Rapid antigen testing or point of care testing continues to be the first line diagnostic for pharyngitis due to the high utility of having that positive test result before a patient leaves your office. When Group A strep rapid antigen testing is negative, there is still a really high rate of unnecessary antibiotic prescribing. This really comes down to doubt on the accuracy of our rapid antigen test performance with that moderately high sensitivity that we talked through in a few slides back. We see that use of multi-target pharyngitis PCR testing that covers both Group A strep and the viral organisms has a higher rate of appropriate antibiotic avoidance compared to rapid antigen testing alone and empiric decision making. What this really tells us, sometimes a negative test result is not always enough to be confident in your clinical decision making. However, if you have a negative Group A strep test combined with a positive viral pathogen, that's more likely to support a diagnosis of viral pharyngitis and confirm it's not a bacterial cause that needs an antibiotic prescription. On the next slide, Steve is going to walk through another case example where we can apply the same knowledge.
Thank you, Dr. Evans. Let's build on our application of nucleic acid amplification testing in a case of overlapping symptoms, which is quite common. Let's take this case. A 22-year-old college student presents with sore throat, high fever, tender anterior lymph nodes, and mild nasal congestion. Pause yourself and calculate the modified Centaur score. Our calculation finds it to be a 2. The clinician for this case ordered a point of care rapid antigen detection test, and it returned negative. Given the compatible clinical picture, high pretest probability for Group A strep, should antibiotics be started? This clinician chose to get a PCR test, and it returned the next morning. It is positive for Group A strep and negative for viral pathogens. Dr. Jansen, your comments on this case.
Well, Dr. Goldberg, I think this case was managed appropriately. When you consider college students, they are considered to be at increased risk for Group A strep pharyngitis compared to the general adult population. So confirmatory testing was indicated with the mixture of symptoms that this patient had. The higher risk in college students is primarily due to environmental and lifestyle factors rather than age alone. If culture or nucleic acid amplification testing is done, We generally defer treatment until the results are known, as happened in this case.
Thank you, Dr. Jansen. One point we want to emphasize is that the conversation really begins with your clinical assessment of the patient, and the diagnostics are in the context of your clinical evaluation and use of the modified Centaur score. That said, let's talk about treatment versus no treatment algorithm, looking particularly at rapid antigen detection testing. For most patients, empiric treatment should not occur, and that's been reaffirmed by a recent IDSA guideline. If the test is negative, especially with high Centaur, modified Centaur scores, one really should do follow-up testing. Dr. Jensen, other comments you'd like to add?
Yes, Dr. Goldberg, for those patients with classic symptoms and a negative rapid antigen detection test, it can be very difficult for a clinician to defer treatment in those which further testing is indicated, such as a college student in case number 2. This scenario demonstrates the advantage of nucleic acid amplification testing over culture. Often with same-day or next-day results, nucleic acid amplification testing can confirm or rule out group A strep infection quickly and support antibiotic stewardship efforts. Waiting on throat culture results can be difficult for patients as well as clinicians, particularly when classic group A strep pharyngitis symptoms are present.
Thank you. Now, our focus so far has really been on care within the urgent care setting, but all of us often confront patients who return with common symptoms over weeks or months or over years. And so that prompted us to conclude it'd be appropriate to talk about ENT referral for recurrent pharyngitis. And the indications for ENT referral are listed there, and they were established by the Paradise criteria published in New England Journal of Medicine in 1984. A couple key points. The clinical features that show high pretest probability for group A strep need to be present. Each episode must have shown the patient had a temperature of 101, there was cervical lymphadenopathy, there was tonsillar exudate, and a positive throat culture. That's the classic tool to confirm the diagnosis for group A streptococcus. That is how one has a definitive clinical episode. In addition, there are other indications for ENT referral, including peritonsillar abscess, recurrent infections that have been unresponsive to therapy, sleep disordered breathing, asymmetric tonsils, and certainly in someone that's had repeat hospitalizations. If you have a question about past clinical documentation, what's advised is to follow the patient and document 2 subsequent episodes before making that ENT referral. Dr. Jensen, with what we just reviewed from that classic criteria, why don't you walk us through this particular case of someone with recurrent episodes?
This is an 8-year-old who has had 8 documented strep throat episodes in the year. All culture confirmed and severe. The parents are inquiring about tonsillectomy. So we apply the Paradise criteria. This patient had more than 7 documented episodes in 1 year, clearly meeting the criteria. And I want to reiterate what Dr. Goldberg said about documentation. Each episode of pharyngitis must be well documented and meet specific clinical features, including sore throat, plus one of the following: high fever, cervical lymphadenopathy, tonsillar exudate, and positive strep testing, either culture or rapid antigen detection. This case shows why that meticulous documentation is essential. For every strep throat treatment provided in urgent care, clinicians must explicitly record whether those classic features of infection were present or absent. Next, I'll discuss some special scenarios you may encounter in the urgent care setting. We talked earlier about recurrent pharyngitis. For recurrent pharyngitis, a more definitive diagnostic approach is needed to prevent continued unnecessary treating and antibiotic prescribing. Consider ordering a multiplex nucleic acid amplification test, even if the rapid antigen detection test is positive, because they test for multiple bacteria and viral causes simultaneously. Multiplex NAATs can rule out other potential causes of recurrent pharyngitis, such as co-infections or pathogens other than group A strep. The next scenario, consider Epstein-Barr virus mononucleosis in patients presenting with symptoms of high fever, exudative pharyngitis, and posterior cervical lymphadenopathy. Often, these patients will present a couple of weeks after the onset of their symptoms or after failing treatment with antibiotics. Remember in these patients to avoid amoxicillin, as it can induce a rash in 15 to 35% of mono patients, typically appearing 4 to 10 days after starting the antibiotic, and sometimes with significant pruritus. And lastly, Dr. Evans mentioned Lemierre's syndrome earlier. This is a rare but life-threatening complication of Fusobacterium necrophorum pharyngitis, typically seen in healthy adolescents and young adults. Generally, a positive NAAT for F. necrophorum in a symptomatic adolescent or young adult is a very strong indicator for antibiotic treatment in order to reduce the possibility of severe complications. Remember, azithromycin is ineffective for this anaerobic bacteria, F. necrophorum. Generally, patients with this syndrome require IV antibiotics and anticoagulation to prevent the development of septic emboli. And finally, we'll wrap up with some key takeaways. Pharyngitis can be caused by several different viral and bacterial organisms, although most are caused by group A strep and viruses. Applying clinical criteria like the modified Centre score can indicate a patient's pretest probability for group A streptococcus and other bacterial causes. Rapid antigen detection tests should be first-line diagnostics due to their relatively high sensitivity, their cost effectiveness, and rapid results. Further testing, either culture or molecular, should be reserved for scenarios of high clinical suspicion and a negative rapid antigen detection test. Standing lab orders can make it very challenging for clinicians to apply best clinical practices. And lastly, when considering further testing, testing for both viral and bacterial causes of pharyngitis can promote proper antibiotic stewardship. Thanks for joining us today.
Dr. Jansen, Dr. Evans, thank you both. We hope our colleagues got some information they can use if they're in the clinic today or tomorrow. Pending some questions from the audience, we have a couple we'd like to review. Dr. Jansen, you talked about that very difficult conundrum of patients coming in, wanting to be efficient, having staff do an initial clinical assessment, and also having the instruction to do standing orders for RADT in certain clinical scenario. What's your overall perspective on standing orders, the benefits and the limitations?
Well, certainly the benefits include increased efficiency, improved patient throughput, and freeing up clinicians to concentrate on more acute cases. And we've discussed the limitations, primarily unnecessary testing and treatment. While some demographic groups, for example, children ages 5 to 15, or those with household exposure, or patients with a history of rheumatic fever, have a higher prevalence of group A strep, testing decisions are still rooted in the presence of those classic symptoms, not just demographic factors alone. So any standing orders should really be based on the modified Centre criteria, which for busy clinical staff can be challenging to perform.
Thank you. Helpful. Dr. Evans, a question for you. In my consultation with clinicians reviewing their test result reports, I am seeing cases of Fusobacterium necrophorum. And there's concern to get the diagnosis right and the treatment right. What's your guidance to our listeners about treatment in those cases?
Thank you, Dr. Goldberg. I think it's a hard question to answer, right? And I understand the challenge that it places clinicians in. We know that Fusobacterium is a colonizer, or can be a colonizer, of the oral cavities, right? Implicated in dental plaque, periodontal abscesses, things like that. But it also actually has relatively moderate incidence rate when it comes to bacterial pharyngitis. And so how do you know when to treat it? I think a lot of that, it comes down of when to test for it, right? So does a patient have a moderate or high modified center score that is really indicative of bacterial pharyngitis and not viral symptoms? Well, we know the clinical criteria aren't 100% perfect. They're a really strong indicator of bacterial versus viral infections most of the time. And so I think applying that clinical criteria, and then when you strongly suspect group A strep, but your group A strep testing continues to come back negative, whether that's rapid antigen testing, PCR, or culture, I think that's when you should really consider Fusobacterium as part of the differential. And if it's positive in those cases with all of those clinical criteria met, that's when you should really be considering treatment. So I like to think about it from all the things that come before you start the treatment and when should it be considered, right? When should it be tested for? When should it be considered? But applying all of that, I think it really comes down to extended and prolonged cases of pharyngitis when you are strongly suspicious of group A strep, but continue to get group A strep rapid antigen and culture and PCR negative tests. I want to follow up with that really quickly though, Dr. Goldberg. I think you can apply the same question to group C and G strep, right? When we think about that, group C and G strep it's sometimes, depending on who you're talking to, recognized as a cause of bacterial pharyngitis, sometimes not, sometimes treatment is recommended. So when you're thinking about this in terms of how you practice clinically, how would you handle a group C and G strep positive pharyngitis result?
Well, in preparing for this conversation, I know all of us reviewed IDSA guidelines, CDC guidelines, reviewed up to date. So I'll share the most recent information we have. With regard to IDSA, and their guidelines were subsequently reaffirmed, routine testing and routine treatment for non-group A strep is not recommended. There's insufficient evidence of benefit, and there's certainly risk of treating that can contribute to resistance. In your talk, you mentioned a few unique scenarios of significant symptomatology where it has to be considered, but the overall context is not routine testing and treatment. Similar guidance from the CDC with regard to group C, G strep, and up to date is consistent with those two guidelines. And they just guide us to consider circumstances where we might want to consider it, such as definitive outbreaks, significant clinical symptomatology in patients who are presenting that are immunocompromised. But all of those in general are less common cases.
Steve, we do have one audience question. Many times our MAs perform both rapid and throat culture swab at the same time. I know this is more of a strategy, but what do you recommend we train our MAs to do?
Dr. Jansen is CMO of a multi-site urgent care center. I'll turf that one to you.
Well, if they are swabbing the patient because they have high clinical pretest probability, and we talked about those indicators, then I understand swabbing the patient one time because it's not a pleasant thing to undergo and sometimes difficult to obtain. So if they can do both at the same time and then save the throat culture in case the antigen detection test is negative, I'm okay with that approach.
Thank you so much. We'll go ahead and wrap up. We thank you for joining us today for this UCA Urgent Care Association Solutions webinar.